Thank you. Good afternoon, everyone, and thank you for joining us today. My name is Gabriela Passat, and I'm the Vaccines for Adults Program Coordinator here at the Immunization Branch at the Department of Public Health. On behalf of our team, I would like to welcome you to our VFA webinar today, the Standards for Adult Immunization Practice. Before we get started, I would like to go over some logistics. There are two ways you can ask questions. One is through the chat box, and please feel free to type in your questions at any time during the presentation. And the second option is to ask via the phone, and you've already heard the instructions for that. We will be addressing all the questions at the end of the presentation today, and we will be posting a copy of the slides and the recording on our VFA webpage. And we'll make sure to send you an email when we do that. Again, thank you for attending today's webinar. Joining us, we have Nisha Gandhi. She's the Adult Immunization Program Coordinator at the Immunization Branch. Nisha will be going over the burden of vaccine-preventable disease and illness, recommended adult vaccines, and current adult vaccination rates, and basically providing us with the background that forms the basis of why we have the adult immunization practice standards. And following that, I will be going over each of the standards, and then at the end we'll have a VFA program update. And after that, we will take your questions. And with that, Nisha, I will turn things over to you.
Thank you, Gabriela. Welcome, everyone. We appreciate you taking the time out of your lunch to listen in on the adult immunization standards. As VFA providers, I know you are well aware of the importance of vaccinating adults, but what we wanted to do today was just step back and think about what we're seeing in the United States, talk a little bit about the burden of disease that we have, and then the vaccines are recommended. That will lead right into a discussion of how do we implement the standards in order to vaccinate all of these adults. So let's talk about the burden of disease first. As you can see, I've listed several diseases on the slide. We've got pneumococcal disease, where we've seen 33,900 cases, about 3,700 deaths in 2013. We've got 89% of the cases, and almost all the deaths are among adults. We've got zoster as well, and I know zoster has been quite an interesting topic lately with the new vaccine out. I'm still seeing about 1 million cases annually. The incidence increases with age, with less than 1 case per 1,000 children, up to 50, and then it goes up to greater than 15 cases per 1,000 adults and over the age of 80. And then we also do see zoster disease in adults over the age of 50, about 10 to 18% as well. And then hepatitis B, although the recommendation has been in place for a very long time and the vaccine has been available for a long time, we still see quite a bit of hepatitis B disease in the United States. Here we've got the incidence among children and adolescents, and then incidence among adults. And what we're seeing really is the high-risk adults that are not necessarily getting vaccinated for Hep B. And then finally, pertussis. I think most folks are aware of pertussis as a childhood disease, and sort of the things that we've been seeing lately and kind of the upswing in disease activity across the United States and in California as well is primarily focused on the very young children, but wanted to remind folks that pertussis is underdiagnosed and underreported in adults, and that we do see 10,000 to 15,000 cases per year, and that we do have pertussis in adults over the age of 65. So, adult vaccines. The vaccines are, as we all know, an important part of optimizing health of the vaccinated person and preventing infections in others. I think many have seen the benefits of childhood vaccination, and now it's sort of transitioning to focus more on adults as well. I do want to mention on the previous slide, I did not include influenza, and I did that purposely because I think influenza is sort of every year we talk about influenza vaccination, so I didn't include the disease activity there, but influenza is, of course, a burden as well. But just a reminder, we do have vaccines against influenza and pertussis, and we know that it reduces the risk of the person vaccinated as well as preventing spread to others. So the adult recommended vaccine schedule is released annually by CDC, and I think many of you have it readily available. It's on the CDC website. The way the schedule is set up is that you've got the age groups above, and then down the side are all the different vaccines. The color coding indicates whether it's recommended for adults with certain conditions or oh, sorry, so it's the coloring, it talks about, yes, how many doses are needed across the different vaccines for the different age groups. So this schedule is just spaced by age. The next table has it by high-risk condition, and this is a far more complicated table right now, but it is sort of an indication of how difficult it is to maintain adults, to vaccinate high-risk adults. Okay, so on to impact of vaccination. We wanted to include this information only to sort of really highlight what vaccine effectiveness we've seen by the different vaccines and the diseases that they affect. So, for example, zoster, the shingles vaccine effectiveness, the new vaccine, and the number highlighted in red is actually the new vaccine Shingrix, 97% against shingles and 91% effective against the post-herpetic neuralgia. When we talk about the pneumococcal vaccine, PCV13 pneumococcal conjugate is 45% effective against vaccine type pneumococcal pneumonia, about 75% effective against vaccine type invasive pneumococcal disease among adults aged 65 and older. And then influenza, of course, varies annually as the strains change from year to year and is based on the antigenic match and also the age and health of the person being vaccinated, about 60 to 70% in younger adults, about 30% in adults 65 and older against medically attended influenza when it's a good match. So influenza is always a bit more complicated than the other vaccines. Hepatitis B vaccine has got 90% effectiveness after completing a 3-dose series, though it can be lower in adults with diabetes. And then there's just numbers here by the different age groups with folks with diabetes. So having talked about all of that, the next thing to sort of think about is where we are with vaccination coverage to see who's protected. So the data in this slide is California-specific data, and it is looking at adult immunization coverage rates for 3 years, 2014, 2015, and 2016. The real thing to look at is just all the different vaccines listed on the y-axis, that we're not seeing a whole lot of improvement and that none of the numbers, the coverage rates, are anywhere close to the Healthy People 2020 goals, with the exception of zoster. But that zoster has a big asterisk next to it because that is the previous 1-dose Zostavax, and now I think we are probably down to less than 1% coverage at this point, just because now the recommendation is the 2-dose series. So again, just sort of a reminder of how much room we have for improvement. Although we are doing better on the age-based recommendations, it's usually the high-risk conditions where coverage is lower. And then when we look at the immunization rates even closely, we do see lower vaccination coverage rates among different racial and ethnic groups, as well as the difference between the uninsured versus insured. And this is where VFA comes right in as providing a safety net for those patients. We know that improving frequency of provider vaccine assessment and recommendations may help reduce disparities. And we also know that we now, with ACA in place for a number of years, we have private plans covering ACIP-recommended vaccines for adults. Okay, so on to challenges, and I think many of you can speak to the barriers that you're seeing in your settings as well. It's just, we know the coverage is really low. We know that patient awareness is also very limited about the need for vaccines among adults. Adults don't generally carry an adult immunization record the way parents carry cards for their kids. Adult vaccination is disparate across many different health providers, and so it's a far more difficult thing to track for a patient. But then, just looking at opportunities, most patients are willing to get vaccinated when recommended by providers, and primary care providers believe that immunizations are an important part of the service they provide, and systematic offering and recommendations from clinicians results in higher uptake. Okay, so this leads us into the adult immunization practice. So the standards are standard stress that all providers, including those who don't provide vaccine services, have a role in ensuring patients are up to date on vaccines. It also acknowledges that adult patients may see many different healthcare providers, some of whom may or may not stock all vaccines. Adults may get vaccinated in a medical home, at home, or a retail setting. And really the aim is to avoid missed opportunities and keep adult patients protected from vaccine-preventable diseases. So the call to action for healthcare professionals is broken into 4 steps. It's to assess immunization status of all patients in every clinical encounter, strongly recommend vaccines that patients need, administer needed vaccines or refer to a provider who can immunize, and finally, document vaccines received by patients, including entering immunizations into immunization registries. Okay, so this is just a list, a very long list of healthcare organizations that support the standards. These are all national organizations in all kinds of different arenas in healthcare. Okay, so now I'm going to turn it over to Gabriella. I listed the steps for the 4 steps in the standard, and now Gabriella is going to go through each one in detail.
Thank you, Nisha. So the first step is assessment. So providers are supposed to assess the immunization status of all their patients at each clinical encounter. And there are a few things that are listed here, a few steps you can take to make the assessment of your patient's immunization histories more effective and to integrate basically immunization assessment into your clinic workflows. First would be to implement protocols and policies that will ensure that patients' vaccine needs are routinely reviewed and that patients get the reminders they need about the vaccines that they're overdue for. And another important thing you can do in your practice is to make sure that systems in your clinic are set up to optimally support the standards implementation. So this can include making sure that your EHR includes the immunization module or that you have the immunization prompts and forms and the clinical decision guidelines are activated in your EHRs and that they are updated periodically to reflect the current adult immunization schedule that Nisha mentioned, which brings me to the last point I wanted to make here, which is the great importance of providers and staff at clinics of being informed and staying up to date on the latest adult immunization recommendations. This table here includes some of the types of reports that you can generate to see immunization coverage rates or gaps in care or track performance. This is a resource from the American Cancer Society. You have the reference here at the bottom. And we adapted it just to give you an idea of the various ways you can look at your immunization data for your patient population and how you can basically tailor the reports to support your immunization goals. And this might be a vaccine-specific statistical analysis, and you can use this in a provider dashboard, for instance. Or you can look at daily vaccinations, and you can use that for vaccine dose reconciliation. Or if you want to target, say, your diabetic patients, 19 to 64, for the pneumococcal polysaccharide vaccine, PPSD23, or Hep B, what you can do, and it's listed here on the 3rd row in the table, you can start by identifying the patient population that has not received a vaccine, and then get a report with their contact information. And then you can either, when these patients come in for their visit, you can let them know that they should be getting PPSD23 or Hep B, or you might want to do a reminder recall to let them know that they're overdue for these vaccines and they should make an appointment to see you. This is a tool that can help with the assessment of your patients. It's basically another way of looking at the schedule and making an initial assessment, and I think it's important to stress out that the fact that you should be using this tool to make the initial assessment. And so HELLO stands for Health Condition, Age, Lifestyle, and Occupation. As you can see, it's an easy-to-use chart that you can that you can look at, and it can help you to make that initial decision. And while some factors can be easily determined, and I'm thinking age or pregnancy status, you will need to ask your patients about the presence or absence of other factors. And once you determine which of these factors apply, you can just look down through the columns and see at a glance which vaccinations are possibly indicated for your patients. In some situations, though, you're not going to need this. And one example here is Tdap. All adults need a dose of Tdap, as well as annual vaccination against influenza. And also note here that not all patients who mention one or more halo factors will need to be vaccinated. And before you make a definitive decision about vaccinating your patients, it's important to, again, look at the current CDC recommendation and see the current schedule, and then make a very informed and complete decision. There are other examples of assessment tools. The National Foundation for Infectious Diseases has an adult vaccine needs assessment tool available for providers. And one note here, even though I downloaded this resource and the one on the next slide 2 days ago, they have not been updated to reflect what Nisha mentioned with regards to the updated age for the new zoster vaccine, which is 50 instead of 60, so you can see the red arrow there. And again, this is another tool, this time from the CDC, and everything should be up to date with the exception of the age for the zoster vaccine, again, 50 instead of 60. So now that we talked about the assessment, what happens after it was determined that the patient is overdue for a vaccine or for vaccines? So next, a recommendation has to be made to receive the vaccine or the vaccines in question. And there is data showing that the recommendation from a provider is the strongest predictor that the patient will actually get the vaccine. So the pressure is high. A strong recommendation is very important, and providers need to be confident in making the recommendation. And it is also important to encourage your staff to use the same vaccine messages when caring for patients. When making a recommendation, you can use the SHARE framework, and you can see what SHARE stands for. So share tailored reasons why vaccination is right. Share a personal story about an experience you know of a person that is ill with a vaccine-preventable illness with hesitant patients. Or you can just share that you or your staff is up to date with your vaccine. You can highlight positive experiences with vaccination. Obviously, you have to address the patient's questions and concerns. Also remind them that vaccines protect them and their loved ones, and explain the potential costs of getting sick. This slide has the results of a survey conducted by the National Foundation for Infectious Diseases regarding the assessment and recommendations taking place. So on the left-hand side here, you can see the green bar, and a large percentage of the providers responding to the survey, 87% of them, say that they talk to all their patients about vaccines. Now on the patient side, and that's on in the 3 bars to the right, you can see that only 18% of the patients said that vaccines are discussed with their healthcare providers, and 31% of them say that vaccines are discussed only occasionally. So the take-home message from this slide, and also combined with the data that Nisha showed you of low current adult immunization rates, shows that there's a gap, and that we need to do a lot more work to increase the rates and to eliminate these gaps in care. So following the assessment and then the recommendation components of the standards, you have to administer the needed vaccines. And some of the best practices for the vaccine administration are the development of standing order protocols for the vaccines you stock, and also to make sure that your practice is up to date with regards to vaccine storage and handling, and developing relationships with pharmacies, health departments, and other vaccination providers where you can refer your patients for the vaccines that you don't stock. And this is the last part, but just as important as all the others, which is document vaccines received by patients. You have to document the receipt of vaccines in your EHR, and you can also provide your patients with vaccine documentation for their personal medical records. Follow up with patients or referring providers if a patient was referred to you to get a vaccine, so you can close the loop and let that provider know that their patient got the vaccine. And last but not least, enter immunization doses to state immunization registries, so CARE. This is helpful as it provides one location that all of a patient's providers can go and see if a patient is up to date on their vaccine. The use of registry is also helpful in ensuring patients get the right vaccines at the right time and in tracking vaccination rates. It also helps to increase preparedness for pandemic and other vaccine emergency responses. It can also be used for quality measures and for coverage tracking. A challenge is that there is currently limited use of immunization systems by adult providers. So according to the paper you see referenced here, only 8% of internists use it. However, progress is being made, and for instance in California there's a mandate for pharmacies to use the registry. So hopefully we'll see a lot more progress in this area. And as a reminder, for the VFA program, we are requiring all the VFA program participants to enter the administration of a vaccine or the refusal electronically in the EHR and into the immunization registry there. This slide has a series of interventions. It's basically the result of a meta-analysis that was done to evaluate the effectiveness of various interventions to increase the use of adult immunizations. And you can see how organizational change, and listed here are standing orders, but also dedicated clinics for prevention services, is the one that is most effective when compared to usual care or a control group. And then going down, you can see provider reminder, patient financial incentives. What I wanted to draw your attention here is that patient education ranks last, and actually according to other informational resources by the community guide, patient education is not a recommended intervention when used alone. So when you educate your patients, because we all know the importance of educating our patients, make sure that you do this in conjunction with other interventions that you are implementing in your clinics, like EHR-related, standing orders, having an adult immunization champion, and so on and so forth. And a successful adult immunization program uses a combination of approaches to improve vaccination rates. And you can see here some combined programs use standing orders, reminder, recall systems. Also listed here are efforts to remove administrative barriers, the use of immunization registries that we talked about, having immunization champions in your practice, and patient education. I have a slide here, and also in the resources portion of our presentation at the very end, I included a shot-by-shot link where you can see other similar stories. I personally am not particularly fond of these kinds of slides, but I think they are good to remind us that these are real diseases that affect real people, sometimes with tragic outcomes. And also very important is that these are all vaccine-preventable diseases, so we can all work more to prevent these instances from occurring. So in conclusion, there is a substantial burden of disease among U.S. adults for which vaccines are available. And however, vaccination rates are low among adults in the U.S. We have the adult immunization practice standards in place. They are updated and supported by a wide range of provider organizations, like you saw on the initial slide. And the implementation of the standards is key to increasing awareness of adult immunization, improving coverage, and reducing racial and ethnic disparities. And there are very many tools and resources available to help providers implement these standards and also educate patients of the importance of vaccination. And we have some of these resources listed, I think, on 3 slides at the very end. So when we post the slides, you're going to be able to have the links to all of them. So now I will move into the last part of the presentation, which is the VFA program updates. So the first update is with regards to orders. The next ordering period for Q3 will open on July 9th, and we anticipate that it will stay open until the 22nd. And another reminder here, so for this year we only have 2 open ordering periods left, and the last one of the year we anticipate is going to be open a little earlier than October, so we think it's going to be open during the second half of September. So for this, I think it's really important to just remember that you'll be ordering for about 4 months. So make sure you place orders that are enough to cover your patient's needs for those 4 months. And for evaluation, we are going to be sending you an email with the information on how to submit the reports. It's going to probably be in the form of a survey, and you're going to be getting that email in the next couple of weeks. So expect to hear more. And now I will pass it again over to Nisha. She will talk about the new vaccines. I know you're all excited to hear about those more.
Yes. Who wants to hear about Shingrix first? Okay. So as mentioned, the Q3 ordering period opens July 9th. And at that time, Shingrix will be available for ordering. We will not be completely shutting down Zostavax ordering, but it will be special order only. And for those who have done special ordering for VFA vaccine, will be familiar with the process. So it will just need a justification. You will see it on your ordering page. So we will have a limited amount of Zostavax for at least Q3. We are still assessing how long we'll keep Zostavax around. I think many of you have also expressed some concerns about getting Shingrix even for your private pay or even for your Medi-Cal patients, that it is right now a very popular vaccine. There's very high demand for this vaccine, and right now GSK isn't keeping up with the demand, although we think that that will be ironed out over the next several months. You received a communication already about Shingrix earlier this week, which talks about the practical guidelines and advice on how you get ready for offering Shingrix. The clinical letter, and in it we'll have a lot of the information that we're seeing questions come in right now through our Q&A here. It will answer a lot of the questions that you have, including timing of Shingrix after Zostavax, the two-dose series, how it's different from Zostavax, and I think we included this information also in the preclinical letter that just talks about the big differences. You know, one is a two-dose series, the other is a one-dose series. Zostavax is frozen, Shingrix is not. So these pieces of information, and then actual administration location is different as well. So all of that information will be included in both places. And so when you should have received the preclinical letter, we urge you to read it carefully. And then the clinical letter that comes out, which is set up very similarly to VFC clinical letters, we also urge you to take a closer look at that, read through it, and if you've got any additional questions, please let us know, and we're happy to answer them. So we plan you'll place your order of Shingrix just as you do with the rest of your vaccines, and then they will be processed in the same way. We are considering possible caps on orders, not necessarily at this time. We'll have to see how the orders come in. We are trying to assess the demand of Shingrix coming in from all of the VFA providers. But again, we're using federal dollars, so we also have to see how many doses are available to California off the federal contract. We think we will be just fine for this first quarter, but just be aware that if we do contact you back, we may have to reduce some of your order. But we will let you know, and you will see it once you go in and start placing your order for Shingrix with Q3. The other vaccine that I wanted to mention is Heplisav, the hepatitis B vaccine. It's a two-dose series. It was FDA approved, I believe, late 2017 or early 2018. I can't remember the exact time. It's relatively new, and it was after Shingrix. And the vaccine is now, we're in the process of being added onto the federal contract, and it's not quite available yet for VFA providers, but we anticipate it will be available in Q4 ordering. And again, that Q4 ordering is a little earlier than usual. Okay, I think those are the only updates on vaccines. So I think we are ready now to take some questions. We are actually way ahead of schedule, so we've got 20 minutes or so to answer any questions you may have. We've had some come in through the Q&A, but operator, if you want to go ahead and see if there are any questions in the audience, we're happy to take some.
Thank you. At this time, we'd like to begin the question and answer session of today's conference. If you would like to ask a question, please press star, then 1. You must record your first and last name to ask a question, and to withdraw your question, you may press star, then 2. Once again, to ask a question at this time, please press star, then 1, and record your first and last name. One moment for the first question, please.
very quiet out there. So.
Anisha, while we wait for questions on the phone.
The first question comes from Mr. Escobar. You may ask your question.
Yes, I have a question. If we see a patient under family planning FAMPAC, can we offer the VFA vaccines?
Family pact, right?
Hello?
Yes, sorry, we are conferring because I think what we have to do is just look into it, and we will definitely get back to you. What's the name of your clinic?
Via Care Community Health Center.
And then the question is whether family pact is considered insurance.
And one way to look at this, and actually a similar question that actually has come in via the chat is, what is an easier way to explain who's eligible and who's not eligible for VFA vaccines? The way we like to explain it is VFA vaccines are truly for those adults who don't have any coverage for vaccines at all. They may be uninsured, or if they are insured, their insurance does not cover vaccines. So if adults may be covered under a program and the program does cover vaccines, then they are not eligible for the vaccines. We do have a very nice handout on ECIC that actually outlines the differences and the different programs that may be covered. There might be different programs such as local initiatives in counties that are not necessarily insurance, but they may actually
they cover certain services.
So we would prefer you to look at that because it does provide a lot of information.
And we'll check to see if family pact is included on that. So we will we'll get back to you on that question.
So FAMPAC is not covered for the VFA vaccines?
If family pact does not cover, does not include all vaccines, then the answer is a patient would be eligible to receive VFA vaccines if the coverage that family pact provides does not include vaccines. And I think my understanding is that they don't certainly cover all vaccines, so they would be eligible to receive VFA vaccines, you know, particularly certainly shingles, pneumococcal conjugate, so the answer is yes, they would be eligible.
Yes, okay. Okay, thank you very much.
The next question comes from Ida Campbell. You may ask your question.
Thank you. My question is back to the slide where they were talking about the TDAP. There was an adult assessment tool on there. Is there a website?
I'm sorry, you're fading in and out. You wanted us to go back to the slide with TDAP.
Yeah, it was back on the slide with TDAP, and they were showing an adult assessment tool.
Oh, okay. Let's see.
I was wondering if there's a website that we could get those assessment tools.
Okay, one section. Is this it?
That right? Yeah, that one right there. Example of assessment tools.
Okay, so it's actually these slides will be posted in the next day or two, and on the page itself there is a direct link to this particular form.
Yes, I see that right there. Okay.
And we'll make sure we get it to you.
Okay. And I also, if I may, I had another question on the gentleman that was just speaking about family pack. Does it cover the vaccines? If they come in under sliding fee or self-pay, then we can give them VFA. But what I'm saying is if it gets billed under family pack, then it won't cover, but we have to change it to sliding fee and self-pay. Is that not correct? If they're eligible, if they don't have insurance, and then they would be a self-pay patient? That covers?
Right.
Okay. All right. Thank you.
The next question comes from Pamela Schreiber. You may ask your question.
Thank you. My question is regarding Shingrix. And this is how soon after the patient has received Zostavax can they receive the Shingrix series? I did look at the information online, and it's a little bit confusing to our providers. There's one place that says 8 weeks, and others says 5 years. And it says there's no studies around that. Is there any kind of definitive answer?
And so I think, as we mentioned, I think all of this is detailed clinical information will definitely be included in our clinical letter as we launch it. What CDC and the webpage is referring to is most of the studies looking at the intervals between both vaccines have been done at over 5 years of age. However, there is no indication that providing that vaccine at less than 5 years interval would be something that wouldn't be recommended. So CDC indicates that you should wait at least 8 weeks after a patient has received Zostavax to administer vaccines. And they do actually have a section there to also consider the age of the patient. So a lot of clinical portion there, but I think they basically what that statement says is even though most of the studies have been done looking at intervals larger than 8 weeks, there is no indication that providing it sooner than, at 5 years, there is no indication that providing it at less than 5 years interval between Zostavax would be contraindicated, and the recommendation is to look at the age of the patient and to wait at least 8 weeks between the doses.
So I think the 8 weeks is the, and I think.
And you will see 8 weeks, appear in most of the recommendations.
Right.
Wonderful. Thank you.
Does that help?
Yes, that's super helpful. It gives our providers a little more definitive answer.
Yeah, it's a complicated response, but I think it's taking into consideration whatever data ACIP had at hand when making recommendations.
Okay. Wonderful. Thank you.
Welcome.
The next question comes from Martha Vasquez. You may ask your question.
Oh, I'm sorry. I tried to cancel it. My question was answered.
Okay, thanks.
Once again, if you would like to ask a question at this time, please press star, then 1, and record your first and last name. One moment, please.
Okay, well, I don't see any more questions coming into the inbox. And I'll ask the operator one last time if we've got any other questions or anything, or if anything's queuing up.
Thank you. We do have one coming in online. One moment.
Okay, great.
Next question comes from Ellen Campbell. You may ask your question.
Hi, good afternoon. So if we still have Zostavax, are you recommending to continue using it or order the Shingrix? And if so, what do we do with the Zostavax?
That is an excellent question that we have been grappling with here. I think every provider is dealing with this transitional period where you still have Zostavax. I think for now, keep Zostavax frozen. I suspect Shingrix availability is going to be a little up and down over the next few months as they iron out their supply. You will be ordering Shingrix for a 3-month period in your next Q3. So one, we don't want anyone pulling Zostavax out of their freezer now and setting it aside. We want you to keep it in the off chance that if you do go through all your Shingrix, you won't be able to order again for Q4 for a little while, and we want you to use Zostavax until it's done. There is a preferential recommendation for Shingrix, but I think until supply is fully in place and stable, to go ahead and use whatever Zostavax you have.
Okay, thank you very much. Yeah, that does answer my question. Thank you.
Do you have a lot of Zostavax?
No, probably less than 10 doses. I don't know off the top of my head what it is.
Sure. I think everyone's got a little bit, and I think at this point, if the Shingrix supply was fully robust and we didn't have to see ordering problems on the private sector, we would probably maybe reconsider that decision. But right now, I think it just makes sense to keep Zostavax in case you do run out of Shingrix.
Okay, thank you.
We were actually going to not offer Zostavax when we launch Shingrix, particularly because the recommendation is that you still provide 2 doses of Shingrix after a patient has received Zostavax. So, you know, instead of 2 doses, you would actually still have to administer 3 doses, and a lot of reminder recalls for clinics to get patients back in. Yeah. Given the limited supply, I think we're reassessing that, so we will keep both open for a period of time.
Right.
And I think a lot of emphasis will be on the clinic to just make sure that we order a little bit of limited on Zostavax so that you can carry, you know, vaccination forward. We will include in the launch letter a very strong statement about the importance of making sure that you are tracking who is receiving the first dose of Zostavax. Of Shingrix, because it would be very critical to make sure that your clinic has plans in place to bring those patients back and complete the second doses of Shingrix. So I think all of that we will make sure that we highlight and include in our letter.
We know the effectiveness of 1 dose of Zostavax. We have no idea what 1 dose of Shingrix offers. We know what 2 doses offer, but there's no data yet on what 1 dose of Shingrix offers. So that's why the recall will be especially important for Shingrix.
So we have a couple of questions online while we wait for more questions on the phone. So here's one for you, Nisha. Does VFA provide flu shots?
VFA does not provide flu vaccine. Most VFA providers have been accessing flu vaccines through their local health departments. There is a state supply of flu vaccine. So if you have not received flu vaccine in the past, then I urge you to reach out to your local health department and let them know of your interest in securing doses for the fall.
The next question is, I was told that there are patients who have health insurance. However, they have to pay a copay of $100 to get Shingrix, which they cannot afford. Will these patients then qualify for VFA?
So the answer is no. Unfortunately, to qualify for VFA, you have to be uninsured. So even though this person has a very high copay, they're still considered insured. I think we've struggled with this, but the rules around who can qualify for VFA is fairly clear. I think there are struggles with copays that we can't, unfortunately, help with VFA.
And I think the uninsured part is very clear to all of you, but the underinsured, we keep getting questions about it. And uninsured, we only refer to those patients who have health insurance, but their insurance doesn't cover certain vaccines. So those patients would qualify, but this is not the case. This is a high deductible or copay, and so these patients would be, like Nisha said, not eligible for VFA vaccine.
So we did have one more come in, and I'm going to touch on it briefly, but it's certainly a complicated one. Can you comment on any specific restrictions on the use of standing orders for vaccines in California law? Is there anything to know about medical assistants using standing orders for vaccinations? So standing orders in California is fairly complicated. I think we have provided some information, and there's a Q&A document posted on our webpage, or if there's a specific question that we've addressed. Generally speaking, the standing orders are tied into the different licensures for the different, so an RN versus an MD, you can look up what needs to be in place for a standing order based on license. The one question that we do get a lot has to do with medical assistants, and as we see it, the only hitch with a standing order for medical assistants is they're not able to independently assess patients for vaccine need, and this is what has been a bit of a stumbling point for many, because the assessment, while the assessment piece has to be completed by an MD, not even an RN. No, but it can be done by an RN, but
physician's assistant.
Right, okay, right. So this one piece has been kind of a difficult thing that many clinics have encountered when trying to put together standing orders. Go ahead. The only thing I would add to that is that in the past, I know that some OB-GYNs have used medical assistants to help remind them to assess immunization, so that they use them as more like prompts. So the medical assistant knows the woman is due for Tdap, for instance, but she would go ahead and remind the physician to recommend the immunization. She herself can't recommend it.
Right. So even the checklists or things that the health maintenance, anything that is generated by an EHR is still helpful because that information just needs to be approved by a provider or signed off by a provider. And we did have one more question. Let's say a patient has already had shingles disease. Are they still qualified for Shingrix vaccine?
So according to information from CDC, there is no specific time that you need to wait before administering Shingrix to patients who have had already herpes zoster. However, providers really should wait to ensure that Shingrix is provided to patients if they are experiencing an acute episode of herpes zoster. These are all great questions. Certainly, we'll make sure we highlight all of these information about timing considerations for giving Shingrix to patients.
Okay. Operator, one last question out there?
At this time, ma'am, I'm showing no questions.
Okay, and I think, the last question had to do where the slides will be available. It is on the ECIC page where you go for all of your VFC info. There's also a tab for VFA, and that's where we have posted webinars from the past, and that's where we plan to post this one. This one is recorded, and so it usually takes us a few extra days to clean everything up, and then we will be, and then we'll have it posted, and at the same time we'll send out a link to all of you so that you are aware of its availability. There is one last question, and I was waiting for this one. Will we be opening VFA enrollment to additional sites? The answer is we're uncertain at this time. We will be reassessing VFA open enrollment or any form of enrollment in the fall. And then after that point, we will certainly let you know what year 3 of VFA looks like for current VFA providers and whether or not we will be extending it to sister sites of current VFA providers.
And as part of that assessment, we will be looking at sites who perhaps have not ordered any vaccines during the first 3 quarters. So after this third ordering cycle, I think we'll be looking closely at sites who are definitely using vaccines, and then maybe sites that were interested at the beginning, but they really are not ordering vaccines, so that we can assess how many new sites, we would be able to bring on board or not. So.
And this is an important point that Claudia is bringing up because our resources stay the same for the next year, and they're already very limited. So in order to enroll additional sites, we would have to look at some of the practices in terms of ordering of the existing ones. So on this positive note, I guess we can see if we have any other questions on the line, and if not, then...
Operator, nothing's queued up, right?
That's correct. At this time, we have no questions.
Okay, thank you so much.
Thank you for attending, everyone, and thank you again for the really great work you're doing. And we'll see you at the next webinar.
And don't forget about Q3 ordering.